Hi everyone, welcome back to my channel. In this week's video, I want to talk to you about severe PMS, a condition we call PMDD for short, or premenopausal dysphoric disorder, or PMDD is what us clinicians call severe PMS, or what you could also call feeling like a complete raging bee before your period. That is what this week's video is going to be all about, how to diagnose it and how you can treat it. So without further ado, let's get into it. Hi, if you don't know me, I'm Dr. Hirsch. I work as the Menopause and Midlife Program Director at the Brigham and Women's Hospital, and I see patients for the perimenopause and menopause transition, as well as other hormonal imbalances such as PMDD. And I think PMDD is very commonly missed. And this diagnosis can really help a woman better understand what she's going through, how to better treat it, and how best to improve her quality of life. Because I think it goes so underdiagnosed or misdiagnosed, I don't think that women get the right treatment. So that's what we're going to talk about in these two parts, is how to diagnose it and how to treat it. But first, there are some risk factors for PMDD that actually I'm going to call Heather risk factors. Maybe they're not traditionally in research studies, they're more associations, and they're also things that I see clinically. So to me, having a history of PMS is a risk factor. Now, PMS is not a pop culture thing, it's a physiologic change. As your cycle goes up and down each month, you have your period when your estrogen's the lowest, that first week after your estrogen's going up, and then you ovulate, and then it goes down and crashes. That's when you get PMS, PMDD, and then you have your period. PMS can be things like acne, bloating, irritability, migraines. Those can all be signs of PMS, and if you think you had them pretty cyclically in your 20s and 30s, these can get worse to the progression of PMDD as you get into your 30s and 40s most commonly. Now, you could still have PMDD in your 20s, but what really gives us that diagnosis is a cyclical pattern. And once you have had a decade more of symptoms, it can be a little bit easier to diagnose. Another risk factor to me is postpartum depression or postpartum anxiety. Again, a system where you're going from a really high estrogen level of pregnancy crashing all the way down to postpartum. And it's that change, it's that loss in estrogen from this high level to this lower level that can really trigger these symptoms of PMS or PMDD or postpartum depression. All of them really do stem from, again, this decline, this rapid decline in estrogen, and your brain really not liking that quick change in levels of hormones. So let's get to the good stuff. How is it actually diagnosed? What are the lab tests that you need? Well, actually, that was a trick. You don't need any lab tests. PMDD is a clinical diagnosis, which means I'm the clinician. I decide based on the clinical history. That actually means what you tell me. So if I have a patient come to tell me who says, every week before my period, I am so moody that I cannot go to work. I will not get out of bed. I feel suicidal. I feel like I could harm myself. I have, ended relationships. I have quit my job. I have done a slew of things in their history in that particular week before their period that have drastically altered their life or really truly affected their quality of life. That in and of itself really does clinch that clinical diagnosis. There is no lab test that is going to help me diagnose PMDD. That isn't to say that I don't think there's other labs that we should check. We want to rule out any other really common things like hyper or hypothyroidism, any vitamin or mineral deficiencies, any electrolyte deficiencies, any types of infection, or anything that could be causing this that's not, purely hormonal. But after ruling out all those other things, if there is no other thing that's obvious, then that clinical history provides a diagnosis of PMDD. And it's really great to know that you have that. Again, one, it's really validating, and two, it can help your doctors better target treatment options for you if we know that you have PMDD. All right, so now that we know you have PMDD, how can we treat it? Well, there's a lot of different ways, but essentially what you need to know from a hormonal perspective, what I'm thinking is, instead of your hormone levels going like this, which is up and down each month, and gets worse in perimenopause, where it's a little bit more volatile and it goes like this. That's why perimenopause and PMDD together is a really, really difficult condition to have a good quality of life with. And I know that for sure because I see patients with it every single day. But if this is what's causing it, we need to try to control the hormones as best as we can. So we use the medications most commonly to help prevent the ovulation cycle or the up and down of hormone levels, right? If you listen to the first part of my video, it's that crashing and declining of estrogen that really triggers the mood changes. So what are our options here? Well, the first, which you may have already tried, is either birth control pills or any other kind of contraception except for the intrauterine device, because all of those other types of contraception stop you from ovulating. And if we stop you from ovulating, we keep your hormone levels steady. So you've got several different options that one could try. You could do continuous birth control pills. And by continuous, I mean active pills only, not taking the placebo pills, skipping them and going straight to the active pill so that every single day you take an active pill. You could do the same thing with the NuvaRing. You could put one in for 3 weeks, take it out, put in a new one, take it out, put in a new one. The same thing with a depot injection or even the implant, which is the Nexplanon. All of those methods not only prevent you from getting pregnant, but they keep your hormone level steady. You could even say, because your hormone levels are steady, you don't ovulate. If you don't ovulate, no egg and sperm, no baby. So actually, contraception and preventing pregnancy is a side effect of these medications, which stabilize your hormone levels. When we stabilize your hormone levels, your brain actually likes that much better. And for many women with PMDD, that seems to really work. Now, there's an entirely other way that I tackle this, and I have a lot of experience doing this. But the other way that I try to tackle it is that week that your hormones are going down and that week before your period, when most women with PMDD report severe life-altering symptoms. What we need to do is boost or buffer your estrogen level a teeny tiny bit here. So sometimes I actually use a postmenopausal estrogen patch during that week, which sounds a little crazy, but hear me out. So there's a postmenopausal estrogen patch that is 7 days. There's one that lasts 3.5 days. But I use that patch, have you pop it on that week before, and it acts to sort of like buffer your estrogen levels so that instead of completely crashing, there is some buffer of that estrogen level. And so you don't have that severe alteration and change in hormone levels, and that really tends to help stabilize people. So why would I use this versus any of the other contraceptive methods I just listed? Well, that really depends on the patient's preference. Maybe she's had contraindications to birth control, she didn't like it, she's tried it, she doesn't want it, etc. Maybe she's in perimenopause or late perimenopause when actually the postmenopausal estrogen patch would work better. And so there are a couple different reasons as a clinician that I help the patient decide. And these videos, of course, are not direct medical advice, but really meant to help educate you. So a lot of that depends on history, preference, and where they may be in that perimenopause to menopause stage. Some women also will use an SSRI or SNRI. Very commonly, I like to use something called paroxetine, also the week before their period. Now, I did a video on SSRIs here, and there's a lot of myth and misconception about SRIs, but an SSRI for PMDD just the week before the period can really, really help. And again, it depends on the severity of the person's mood, it depends on their volatility, it depends on so many other things, but not so much that it's used every day, although some women are already on a medication like an SSRI and SRI that they're using every day. But if they're not, and there's a little hesitancy there, what I do is use it just leading up to the period, again, so that they can have the most functionality during their bad week. If you feel like you have PMDD and you feel like you're not being heard, what I really want you to do is journal and track. So I think it's best to do it on one of those old school calendars where you can really open it up and see. You can do it on an app on your phone. But what I want you to do is really track your mood and your periods. So if you find that very cyclically before your period, you are having these severe type of symptoms, it's affecting your quality of life, you need to make sure it's well documented and you bring it to your doctor, because That's how they're gonna diagnose this, by your clues, by what you tell them. So I know it's a little bit of work, but it can go so far in getting you the right diagnosis and then getting you the right treatment. This can be even more severe and pronounced in perimenopause, and symptoms can start in the mid to late 30s and definitely in the 40s. And that's when perimenopause plus PMDD kind of come together to just create this perfect storm. So if you think you have risk factors like bad PMS, postpartum anxiety or depression, be on the lookout for these things. Most menopause experts also know a lot about PMDD. So even though menopause and PMDD seem so far away, again, most menopause experts are really good at understanding how hormones affect mood. So you can try a menopause expert. So go to menopause.org, search under find a provider, and you can hopefully find someone who, if you find that, by going to your internist and your OBGYN, you're not getting very far, then I would definitely recommend a NAM certified menopause expert. All right, guys, thank you so much for watching my video. If you found this really helpful, if you're part of any PMDD groups or you want to post it to your social media, please do. If you haven't already, subscribed to my channel. That helps me so much. I make new videos that come out every Monday. I talk about everything women's health, perimenopause to menopause to sexual health and more. Let me know in the comments what else you want to hear, and I thank you guys so much for watching. See you next week. Bye, everyone.